Good afternoon. Welcome and thanks for joining us for today's HIS Talk webinar, Pairing a High-Tech Clinical Logistics Center with a Communication Platform for Quick Patient Response. It's brought to you by Voalte and Zebra. I'm Lori from HIS Talk and I'll be moderating. We have two speakers today. First up will be James Schatterer. James is a health informatics supervisor at Nemours Children's Health System. Joining James will be Mark Chamberlain. Mark is a clinical applications analyst also at Nemours Children's Health System. And with that, I'll turn it over to you, James.
Great. Thank you, Lori. As she said, my name is James Schnatterer, and I have been with Nemours for more than 25 years and in the healthcare industry, I hate to say this, but over 30 years. My co-presenter, Mark Chamberlain, has been with Nemours for the past 8 years, and Mark helped to build most of what we are presenting today. So I hope you enjoy the presentation, and again, thank you for taking time out of your busy day to attend today. So Nemours was founded in 1936, and our first hospital was built on the grounds of Mr. Alfred I. DuPont's estate in Wilmington, Delaware, and we opened the doors to our first hospital in 1940. Our second hospital, the Nemours Children's Hospital, was opened in 2012 and is located in Orlando, Florida. We have specialty care centers across the entire Delaware Valley and the state of Florida, and continue to grow and expand, and are now exceeding 8,000 associates throughout our health system. Nemours is one of the nation's leading pediatric health systems. We provide care for more than 410,000 unique patients with close to 2 million encounters annually. We are leading the way to help children grow up healthy using a holistic and multifaceted approach to reach children and families where they live, learn, work, and play. The picture you see on the screen, the hospital on the top part, is the Alfred I. DuPont Hospital for Children, which is still located on the grounds of Mr. DuPont's huge estate. And on the bottom screen is the Nemours Children's Hospital. The different lights, colors of the lights that you see on the patient rooms are actually controlled by the patients themselves. They can set the mood for their room by changing the colors themselves. So it does look really, really cool at night when you're driving through Orlando. We're going to talk to you today about leveraging technology as extra eyes and ears for the nurses on our inpatient units. This is a picture of our Clinical Logistics Center. It is located at the Nemours Children's Hospital in Orlando, Florida, and the medics that you see throughout the room are our nurses' second set of eyes and ears. From the Logistics Center in Orlando, the paramedics monitor patients at both hospitals in Wilmington and in Orlando. They can monitor up to 400 patients around the clock, and they are able to see if any of the patients display signs of difficulty. They can initiate codes, staff assist for immediate assistance on the units. And we do this not only by monitoring all of the screens that you see there, but we also have high definition cameras that are accessible by the medics. And I'm going to go into more detail about that later in the presentation. But that is the Clinical Logistics Center. We wanted to just mention right off the bat some success stories by using our Clinical Logistics Center. We've been able to catch seizures when no one is around, 0 delays to get the patients the help they need exactly when they need it. Early warning signs during a blood transfusion catches blood transfusion reactions. A text to the nurse about a lead placement or rhythm changes results in doctor interventions, and real-time chart auditing confirm national standards and protocols are being followed. With that, I'm going to turn it over to Mark to go into more detail about how we've been able to pull this off.
Thank you, James. All right, so what you see here, of course, is the logistics center that James already covered. What you see here, of course, is the logistics center that James already covered. At each of these workstations, staff is logged into several applications at all times. Voalte Messenger for texting in Voalte with the staff. They're also logged into Voalte 1 on a TC51, a Zebra TC51 for alarm escalation. Logged into Spoke Messenger, which is our middleware for sending urgent alerts or notifications to preset groups in that system. They're also logged into TalkGuard from Guard RFID, which is our patient tracking system. They're logged into Responder 5, our nurse call system, into Epic, which is our EMR, ICU monitor, and of course email. We are staffed with licensed paramedics who work 10 to 16-hour shifts with breaks every 4 hours. So there are 5 workstations in the room. 3 are dedicated to Alfred I. DuPont and Wilmington, Delaware, and then 2 dedicated to NCH Orlando, and that's based on census. The 6th workstation you see in the top left, that is the work area for our house supervisor. So this is a list of the most impactful responsibilities of the paramedics in the logistics center. Physiologic monitoring, of course, protocol-driven responses, and some of those responses are initiated by clinical rules surveyed by Epic Monitor you see below, CLABSI, CAUTI, neonatal sepsis, and PEWS. So here's a diagram of how we integrate the systems to notify the nurse or care team member of an event in the patient room. For a red alarm event at the Philips monitor, a vent alarm, or a patient call from the Responder 5 nurse call system, we send those events to Spoke, which contain the assignments for the correct nurse or care team member to receive the alarm. From there, Spoke sends to the Voalte device that the nurse or care team member is carrying, and then this will tie in with the logistics center as they are assigned to the last tier of escalation. So this is our Philips patient monitoring presence in the logistics center. Nursing leadership at NCH and Orlando opted for no monitoring at the nurses stations on the med-surg units and the HEMONC unit, which means that on that big wall there, those big screen TVs are the central stations for the med-surg units, and that's making up 72 locked sectors. All the sectors on the wall there are locked. There is no keyboard or mouse option for those large flat screen TVs. For AIDHC, there's only overview stations in this room as the central stations are on the units up there. And there is a 1 gig circuit that's used to connect the logistics center to AIDHC with backup routing options through a major networking hub of ours in Jacksonville. So at both hospitals, we send patient monitoring alarms to Voalte 1 and Voalte Me users. We only send specific red alarms to better manage alarm fatigue. Our middleware provides the escalation process. It gives the nurses the ability to immediately escalate if they're not available to respond. And then if the alert goes unresponded to, then the system will auto escalate at 30 seconds. Charge nurses and the logistics medics are the last tier of escalation. The medics process for responding once they receive an alert is to message the nurse, and if no response is received, then they'll go ahead and call the nurse directly. So here's a flow chart. It represents the paramedics workflow in response to a pulse ox alarm, as you can see, which could ultimately lead to activating a code blue or a rapid response. At both hospitals, we use the Responder 5 nurse call system. Of course, there are 100 devices installed at both hospitals. In the logistics center, each workstation has a responder console phone that you see in the bottom right. This device identifies the event with the event type and location. It also allows for communication into the patient room. The medic can connect to the pillow speaker and headwall unit into the patient room to have a conversation with the patient and family. We use a remote network concentrator provided by Roland. This converts the Responder 5 Layer 2 traffic to Layer 3 on our network, and then vice versa when that traffic reaches the other facility. The medics are part of the primary notification for these urgent events, and will audio and video into the room to assist with the response by monitoring compressions or acting as a messenger to contact a lab or imaging or another provider if needed. So I want to dive into an integration we use to give the nurses the ability to call into the patient's room to converse with the patient and family. This is prompted by a nurse call alert being activated from the patient, either a nurse or water, toilet, or pain from the pillow speaker. As you can see on the device on the screen, that is the alert which is received with the 3 options of accept, reject, and accept and call. Accept ends the escalation process, giving the nurse that responded ownership of that call. Reject would let the escalation process take over and immediately escalate to the next person. And accept and call stops the escalation process, but also initiates a call directly into the patient's room. So how this is accomplished is through this diagram here. So the alert is initiated from the nurse call device. That alert from Responder 5 goes into Spoke, and it includes the dial pattern for that room, and via Spoke is sent to the appropriate care team member to their Voalte. When the accept and call is selected, it still has the alert still contains that dial pattern, which is sent to our Cisco call manager. From there, the Cisco call manager recognizes the prefix and is sent to the Roland SIP server. Once it's received by Roland, the SIP server chops off that prefix and then identifies the room to connect the call to and sends it on to the devices in the room. Now, from the Voalte phone, this just sounds like a regular telephone call. However, in the room, it's an intercom conversation so that the nurse can speak with the patient and the family in the room. Spoke Messenger is our middleware at both locations, processing the patient monitoring and nurse call alarms to Voalte. At NCH in Orlando, the medics use the middleware client to send codes, census notifications and updates, equipment outages, or even notification that an inspector has arrived on site. These messages are sent to various groups in Spoke, and these groups are static, meaning that they're preset, they're not edited between shifts. And thanks to Voalte Platform, we were able to replace messaging to this managed Voalte Blast group in Spoke with the send announcement option, which is a quick and easy way to send a message to all Voalte users online. Wanted to share about another way we leveraged this integration for a continuous improvement project that we had at NCH last year. We wanted to focus on discharge planning at admission, communication across the care team, and coordination of the room turnover process. So we created 4 room turnover buttons on the staff terminals that you see at the top right there. We have one of those in each of the inpatient rooms. We created room dirty, cleaning in progress, room clean, room ready to capture each step of the turnover process. So room ready notifies environmental services that the room is now empty. It also notifies the logistics center that the discharge has occurred, and it updates the room in our EMR as dirty. So when cleaning in progress is pressed, it notifies environmental services management that the environmental services tech has arrived to clean the room. And then when room clean is pressed, it identifies or notifies EVS management that that tech is complete. And it also notifies our patient care techs or nurses aides that the room is ready for the finishing touches prior to the next patient. And this also updates our EMR that the room is clean, but not yet ready. And then, of course, room ready notifies the house supervisor, the unit's charge nurse, and the logistics center that the room is ready for the next patient, and then changes that bed status in our EMR to ready. We use rules like the next button cancels the previous button to mitigate issues with it being a manual process. Our CI team has been collecting data since we went live, and I'm looking forward to see how we've improved turnover times. So at this point, I'd like to turn it back over to James to share about integrating data from the EHR.
Thank you, Mark. Appreciate that. So our electronic health record is Epic. So we use Epic, and we refer to that as Epic Nemours 1. That's what all the associates call it, and that's any of our notifiers that go out. We refer to it as Epic Nemours 1. And it allows for seamless integration because we have one EHR database for our entire enterprise, both in Florida and Delaware. And the Clinical Logistics Center uses the Epic data to provide an added level of patient safety, which allows them to do their 24/7 monitoring of our patients at both hospitals. So this is Epic Monitor. An Epic Monitor displays in table format alerts designed to detect real-time specific patient characteristics within the EMR to the paramedic. So for example, the combination of fever and an elevated white blood cell count in a patient with a central venous catheter alerts the paramedic to search the EMR for specific antibiotics to avoid a central line associated bloodstream infection. The pews entered by the nurse are also electronically tracked to assure proper escalation of monitoring and potentially higher level of care if needed. So predictive analytics helps to prevent hospital-acquired infections such as CLABSI and CAUTI, and we're able to do that with Epic Monitor. I had mentioned earlier that we have high-definition cameras in the rooms. So the bubble in the middle is what the camera looks like in the ceiling in the room, and the screenshot or the picture on the right is the view that the medic would have in the Clinical Logistics Center. That camera can zoom in and view the rise and fall of a patient's chest, can zoom in pretty much anywhere in the room. And the audio connection that we have is done through the Responder 5 system that Mark was talking about. And the medic can call directly right to the pillow speaker to converse with the patient and family. The medic can confirm by direct visual confirmation of the patient through these bedside cameras to distinguish true alarms from nuisance false alarms, and they can do it in real time. This technology allows for hands-free voice communication by the bedside staff in the room during acute clinical crisis and or resuscitation. So they can give direction to the medics in the logistics center if they need assistance, if they need someone contacted, if they need something looked at in the chart. They can do that, simply by conversing directly with the medic. So alarm desensitization becomes an increasingly common risk to patients. So the failure to appreciate, acknowledge, or respond to alarm is alarm fatigue. So to give you an idea, out of 1,137 total physiological alarms, 21% or 244 of those alarms were false alarms. 18% of those alarms had actions taken by the paramedics. And just to give you an idea of alarm fatigue, the major concern or issue with alarm fatigue is the Joint Commission identified alarm fatigue as a primary cause for 80 hospital deaths reported between 2009 and 2012. So we wanted to dive into the alarms that the medics are responding to. And wanted to also show that 72% of the actions resulted in either an audio or a visual communication with the room itself, with the patient's room. 21% of those 115 communications were audio only, and then 79% of those communications were audio and visual. So here's a breakdown of those 115 alarms that 66% were low SpO2, 17% tachycardia, 10% bradycardia, 7% were for other reasons. And from those 115 that required a medic response, 45 of them required a secondary action by the medic, 26 were text to providers via Voalte.me, and 17 were phone calls to the nurse's Voalte devices, and in 2 cases, a rapid response was initiated. So here is the initial action and the secondary action performed by the medic and the resulting clinical intervention. So for example, a low pulse ox alarm led to audio-visual communication. A call to the unit resulted in an increase of supplemental oxygen. A high heart rate alarm led to audio-visual communication and the ordering of lab tests and IV fluids. So we mentioned we use the Voalte platform and Zebra's TC51 handheld computers. We have over 800 shared Zebra TC51s and with the Voalte 1 app on it, and another 550 personal physician smartphones with the Voalte.me app. We recently made the switch from a consumer-grade smartphone to the Zebra TC51 for our enterprise. The TC51 is extremely durable. It's made for everyday clinical use, and the clinical staff really love their new devices for a number of reasons, especially because the battery remains charged for their entire 12-hour shift. So once they pick up their device at the beginning of shift, they have that device the entire time. It doesn't need to be redocked. They have it on their body for their entire shift. They also love it because when they drop the device, which does happen, it doesn't break. And from a support end, we like that as well because it has reduced the number of call outs to replace a shattered screen on a consumer grade smartphone versus this hospital grade device. And the clinical staff, the other thing that they love about this device is they can clean it without worry using all of the same cleaning products that they have on the inpatient unit to clean all of the other hospital equipment they have. They just consider this another piece of hospital equipment and use the same cleaners. Derek, one of our PICU charge nurses, states, "I wouldn't feel comfortable walking away to another room if I didn't have my Voalte phone with me. Having peace of mind that Voalte will instantly notify me of any critical alarms is comforting and alleviates anxiety." Dr. Torres, our chief of the NICU at NCH, our hospital in Orlando, added, "Voalte allows us to take inefficiencies of communicating out of the equation." So the Clinical Logistics Center has been a big success, and we are in the process, it's been such a big success that we're in the process of building a second Clinical Logistics Center at our hospital in Delaware, and then each of those Clinical Logistics Centers will act as a backup for the other. So if we were to have a major hurricane that impacted Central Florida, we could still monitor both hospitals from Delaware, or if we had a nor'easter come through with that in the Northeast that dropped a ton of snow and had some type of an impact in Delaware, we would be able to monitor from Orlando as we do now. So with that, I'd like to turn it over to our Voalte partner for the presentation.
Yeah, thanks, James. Hi, everyone. My name is Angela Kaufman, and I manage our product marketing department here at Voalte. Nemours is a great customer and a wonderful example of how hospitals around the U.S. are leveraging Voalte Platform to improve clinical workflows, patient care, and staff engagement. Our platform is made up of 4 solutions that you can see on the slide here: collaboration, management, analytics, and integration. The Nemours team highlighted some of these solutions earlier in the webinar, such as our mobile applications, Voalte One and Voalte Me, our desktop application, Voalte Messenger, and of course the various alarm and alert workflows that Mark and James went through. If you have any questions about the Voalte deployment on Zebra devices at Nemours, we'll be providing more information on how to get in contact with us after the webinar. So now I'd actually like to hand it off to Chris Sullivan to share about Zebra technologies. Chris?
Thank you, Angela. And Zebra is very pleased to play a part in this very innovative and strong solution that Voalte and Nemours are delivering. My role at Zebra is the healthcare practice lead. Our company focuses on applying advanced technologies into the healthcare workflow. We are a global market leader in a diverse range of products, ranging from printers and wristbands and scanners and RFID, handheld computers, and much more. We have over 350 healthcare designed products with specific healthcare workflow needs in mind when those products are designed. We heard an example of that through this story at Nemours with our mobile computer product that is designed for the healthcare environment. Our company focus in healthcare is on 3 solution areas. One is around patient identity solutions, which involves identification accuracy of tasks and people and patients. Secondly, we help assist with clinical mobility solutions, as is highlighted here in this example. And we also provide real-time location solutions and operational intelligence. Recently, we've made some major investments. In February, we announced announced the acquisition of a smart label company named TempTime, which is temperature sensitive labels. And we also launched an IoT platform in June of 2018, which helps with the flow of information in a seamless, clean way within the healthcare environment. Thank you for the opportunity to be part of this session today.
All right. We'd like to open it up to the audience now for questions. Please use the questions box in the GoToWebinar console to submit your questions to our speakers. The first question: where and how do you capture output room turnover metrics and make them available for environmental service management?
I'll take this one. So actually, that is captured. All of the room turnover times between each step of the process is captured in the Responder 5 system. They do have reporting options, but we found it more efficient to use a reporting tool connecting to the database and just grabbing the information ourselves. And we do turn that over to our contracted EBS company for the turnover times.
Mary would like to know, what consumer phone did you use prior to Zebra, and do providers bring their own devices?
So providers do not bring their own devices. Providers are issued a customer grade regular smartphone. They have the option. Well, what we used before was an iPhone with a Mobi battery pack attachment, and what we use now are Nemours issued smartphones for the providers that they carry with them, and we use Mobile Iron to make sure the device is secure. And then the TC51s are shared on the units by all the supporting staff. Mark, I don't know if you wanted to add anything to that.
Yeah, so we went through several iPhone versions. We started with the 3GSs and then onto the 4s, all the version of 4s, and then onto the 5s, all the versions of 5s. But when Mophie had stopped producing the external battery pack is when we began shopping for our next device, and that's when we compared the two, we obviously chose the Zebra TC51 to move forward with after the iPhone 5.
All right. Can you tell us a little bit more about your efforts to alleviate alarm fatigue? How do you ensure that nurses and others aren't being interrupted by too many alerts coming to their smartphones?
Well, we do have an alarm management committee, and we meet on a monthly basis to kind of review alarms for the previous month, review alarms compared to last year. We also update on different things between the units that we're trying. I believe swapping leads. You'll have to excuse me, I'm not clinical, but there's a number of steps that they're also taking on the floors to reduce the amount of alarms. So I'd say it's just something we meet regularly about and try and keep a close tab on.
Mark, did you want to mention the different tiers? I think that was that part of the question as well.
Well, we do. Yeah, we do have tiers of escalation for the alerts. So there's not just one or the same nurse that's being alerted over and over. So there is assistance in that escalation process on the unit and outside of the unit.
Pete would like to know if you can explain your change management process for alerting. For example, when you change who gets alerted and how long before an escalation and to who, how does that change process proliferate through the organization?
Well, it helps with leadership, having a good understanding of the alerting process. Other than that, we like to keep those decisions not really at a unit level, but at a higher level, so that the changes do go down to all units. We try and keep things as similar across the units as possible. We have quite a few nurses that float. So really, with that with their understanding, leadership that is, and just the explanation of the changes to come, then we either decide on possibly a pilot unit for a period of time to see if that's the right way to go, and then we would coordinate with all managers to get the word out to all staff, and then of course we would use notifications through Voalte when that time for the change does occur. Hope that answers your question.
Thank you. You mentioned escalation of alarms. When a nurse is busy, how are alarms escalated to the next available person?
So built into the escalation process, we have options to auto-escalate. If you recall in one of the slides, the reject option is part of the alert for the nurse that receives it. They can, once they reject it, it is escalated automatically, immediately, or it falls back to the escalation process in the system, and that is an option in our middleware.
All right. Do you have a set of guidelines for when the medics should send a text versus when they should pick up the phone and make a call?
I believe it's always a text first, unless it's urgent. They can go as far as to contact the room directly without any interaction with anyone on the floor, based on what they're receiving. So they could audio and video into the room first, actually, and then determine what's going on, and then reach out to the staff. So depending on the urgency, I think they try to usually start off with a text. But if it's an emergency, they will call the unit. Sometimes even just go ahead and initiate either a rapid response or a code blue, and get that message out to everyone that responds immediately.
Thank you. Oh, another one just came in. Mike would like to know if the speaker can talk more about the Clinical Logistics Center. Where is it located? How is it staffed? Who staffs it? And what is the scope of their focus?
So it was a concept that was part of this hospital at construction. We opened in 2012 here. So this large, 2-story sized room was part of the construction with the design in mind. And we do hire licensed paramedics. Again, I'm sorry, I'm not clinical, but we hire licensed paramedics because they're able to use that training in their responses to signs that they receive from the patient. It is staffed 24/7. All patients at both hospitals are monitored 24/7. And what was the last part of that question? I'm sorry.
The hospital that it's in, the Nemours Children's Hospital in Orlando, Florida. I think they were asking for which hospital, how we manage.
Yeah, and they asked about the scope of the focus, which I think you answered when you said every patient.
Well, yeah, I mean, and really they are the second set of eyes and ears for nursing. They even monitor patient records to make sure that, James, you might be able to better answer that, but they're really making sure that those records are updated as needed. So they're really just the second set for nursing.
James, do you want to add anything?
They'll do real-time chart audits to make sure protocols are being followed. So there's because they are in that room 24/7. They're constantly monitoring all of the monitors that you saw on the screen, as well as then going into the Epic the patient's chart in Epic, and doing audits as well.
Okay. Beside communication, what other ways do the nurses use the TC51?
We are about to pilot the use of Rover, which is an Epic application. So they will be able to do some patient documenting within the while using the handheld computer. They'll be able to, when we implement Rover, they'll be doing scanning with the device as well. So they won't need a separate scanner. They can do scanning capability with the device. Mark, what other apps?
We do have a couple of, we got a couple extra apps on there. Our radiology department is enterprise with their on-call rotation. So we do use Lightning Bolt application on there that gives the radiology staff access to that schedule. We also use an application called Ease in our OR and in radiology that allows for our staff to update the families during longer procedures.
All right, I'm pausing for a second because each time I think it's the last question, another one comes in, but it does look like that was the last question, which will conclude our webinar. Thank you everyone for joining us today, and thank you James and Mark for the informative presentation. Attendees, watch your email for links to the recording of today's webinar, as well as a PDF version of the PowerPoint presentation. We look forward to seeing you at our next HIS Talk webinar. I hope you all enjoy the rest of your day.
Thank you, everybody.